Doug Elmendorf, the Dean of the John F. Kennedy School of Government at Harvard University. Welcome. Teresa Miller, Pennsylvania Insurance Commissioner. What an honor to have you here. Gary Cohen, very familiar to the Capitol, former Deputy Administrator, Centers for Medicare and Medicaid Services. To our distinguished witnesses, your testimony today is very important to us because stability of the market in the marketplace is essential to the success and the good health of the American people. I am my privilege now to call to order our hearing, Action Now, Updating and Improving the Affordable Care Act to lower cost and ensure options for families. We Democrats take great pride in the success of the ACA lowering costs, protecting the health and financial security of families. Covered, more than 20 million previously uninsured Americans are covered, but that's just the beginning of it. While we talk about the additional names, that's important. But what is also important are the over 100 million people, 150 million people who have expanded benefits at lower cost and more access under the Affordable Care Act. There's quality for every American, no matter where they get their coverage, and cost. Since the ACA, healthcare cost growth has been slowed by the lowest on record. But Republicans have been working from day one of the Trump to drive up cost and sabotage the marketplace as a pretext for passing Trump care. So I want to just focus on the word cost, 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 cost. Every version of Trump care would hit Americans with crushing health bills, sky-high deductibles, soaring out-of-pocket costs. Under Trump care, for example, a middle-aged, middle-income person would face a choice between increasing his or her deductible from $5,000 to $13,000 or paying hundreds or thousands more in premiums. So let me talk about a lower premium. The costs are still going up with higher deductibles and higher copays. A 64-year-old with income of $56,800, a 64-year-old making $56,800 would be forced to pay $11,000 more for the same level of coverage he or she has today. $1,700 under the Affordable Care Act, over $14,000 under their pill. According to estimates, premiums for those under 40 could be up to 70% more expensive if they want maternity coverage. And without coverage, giving birth costs an average of $30,000 or $50,000 for a C-section delivery. As mother of 5, I say that, and grandmother of 9, that's totally unacceptable. Earlier this month, Senator McConnell said, if my side is unable to agree on an adequate replacement, then some kind of action with regard to the private health insurance market must occur. Trump care also includes 2 provisions Democrats have long been calling for: cost-sharing reduction payments and reinsurance to stabilize the marketplace and drive down costs. Republicans must end the sabotage and join us in passing stabilizing measures before the August recess. Again, we're honored to be joined by our distinguished board of experts on health care and coverage in America who will share their thoughts with us. But first, I'm going to yield to the distinguished co-chair of the Steering Policy Committee, a leader in protecting the good health of the American people, a champion on this cause, Congresswoman Rosa DeLauro.
Thank you very much, Madam Leader, and thank you for putting together and organizing what is today a critical hearing. I want to welcome our panelists this afternoon to say thank you for being here to discuss the ways in which we can improve and strengthen the Affordable Care Act for the middle class. My colleague and co-chair, Congressman Swalwell, will be here as soon as he can. He is in the Intelligence Committee, and they have a full plate today as well. So, but this is about what all of you in your testimony have spoken about, what the leader has talked about, and that is today to focus in on stability in the marketplace and what that means. Today, or tomorrow, the Senate will hold their procedural vote on health care repeal. While we do not know what exactly they are voting on, we know that the Republican proposals to repeal and replace the ACA would unravel protections for patients with pre-existing conditions, eliminate coverage for essential health benefits. What are essential health benefits? Prescription drug coverage, hospitalization, pregnancy, maternity and newborn care, lead paint poisoning screening and testing. It would make health care unaffordable by raising premiums and deductibles. A repeal without a replacement would also mean 32 million people without insurance. Instead of pursuing a repeal, we ought to work together in a bipartisan manner to reform the current system and to fix the problems that exist. We cannot leave the American people behind in this process. We need to stabilize the marketplaces and ensure there are affordable, high-quality coverage options for people living in bare counties. We also need to keep premiums down and stabilize the marketplace, which can be done with a reinsurance program similar to the Medicare Part D reinsurance programs. And it's also interesting to note that we have a document that's been prepared, reinsurance, House Republicans, House Democrats, Senate Republicans, Senate Democrats, and Republican governors also propose reinsurance, a reinsurance program. We are deeply disturbed by the Trump administration's attempt to sabotage the Affordable Care Act, a law they are entrusted to uphold. Despite the narrative of, quote, implosion, more than 10 million Americans signed up for coverage in the ACA marketplaces in 2017. And the enormous uncertainty created by the Trump administration's refusal to commit to continue cost-sharing payments has caused insurers to propose 2018 premium increases. The biggest economic challenge of our time is that too many people are in jobs that just do not pay them enough to live on. We cannot put more American families in jeopardy by raising the cost of health care. We need a country and a health care system that works for the middle class and the vulnerable, not just the wealthy and those with the most lobbyists. And with that, I want to say a thank you to all of our speakers today. Thank you for your work and all that you do to inform our debate, and we look forward to your discussion. I will now introduce our panelists, and then we will proceed with testimony. And we will start the testimony with Doug Elmendorf, former director of the Congressional Budget Office, current dean of the John F. Kennedy School of Government at Harvard University. Previously, he served as director of the Hamilton Project at the Brookings Institution. He's a leading economist, a lifelong public servant who has devoted his career to examining the relationship between academic research and public policy that affects the lives of people and the lives that they are actually living. At the helm of the CBO during the fight to pass the Affordable Care Act, Doug knows better than anyone how the organization works, how it evaluates costs for the American people. And we look forward to hearing from you on the evidence-driven adjustments we can make to ensure that the middle class is not left behind as we move forward on health care. Teresa Miller is State Insurance Commissioner of Pennsylvania. Pennsylvania is the 5th largest insurance market in the United States in terms of premium, volume, and the 14th largest insurance market in the world. And what she talks is about urgent action needed, ACA marketplace stabilization. During her tenure as insurance commissioner, Miller has increased consumer protection, outreach and education efforts, increasing transparency, and advocating for working families. She is an expert who deals with the insurance market every day. She works to ensure that Pennsylvania has no bare counties and is a national leader on insurance issues that impact American workers. And prior to fighting for Pennsylvania consumers, she served as acting director of the State Exchanges Group, the Oversight Group, and the Insurance Programs Group in the Federal Centers for Medicare and Medicaid Services. Let me also introduce Gary Cohen. Gary is the Vice President of Public Affairs at Blue Shield of California, where he leads the government affairs team in advancing Blue Shield's public policy initiatives, such as reducing the uninsured rate, stabilizing the individual health insurance market, topics that we look forward to hearing more about from him today. And I think it was you, Gary, who said in your testimony that stabilizing the insurance market is a pocketbook issue. Mr. Cohen has more than 30 years of legal, business, and regulatory experience. Prior to his work at Blue Shield of California, he served as Vice President of Enterprise Regulatory Strategy and Policy at Kaiser Permanente. Director also of the Center for Consumer Information and Insurance Oversight at the Centers for Medicare and Medicaid Services, which was instrumental in implementing the Affordable Care Act in the private insurance market. So thank you all for joining us. We will begin our testimony, and we will start with you, Mr. Elmendorf.
Thank you very much. Madam Leader, Congresswoman Laura, members of the committee, I'm very pleased to be here today. I'm very pleased to be here today. You are taking up the critical subject of how to stabilize the marketplaces in which millions of Americans buy private health insurance for themselves and their families. Some members of Congress and some senior members of the Trump administration have asserted that the marketplaces are intrinsically unstable because of flaws in their design in the Affordable Care Act. But the evidence does not support that assertion. The evidence shows that the marketplaces have helped millions of Americans buy private health insurance that in turn has enabled them to obtain the health care they need. Numerous independent analyses have concluded that under the policies in place before the current administration took office, the marketplaces would be stable throughout most of the country in the years to come. Unfortunately, the evidence also shows that the marketplaces can be destabilized by the Trump administration. If the marketplaces collapse, that will be because the Trump administration takes or does not take certain important actions. The responsibility will lie with the Trump administration, but the consequences will be felt by millions of Americans. In my judgment, 3 actions are paramount to stabilize the private individual health insurance market. First, payments to insurers for the cost-sharing reductions they are required to provide to lower-income enrollees must continue. Without those cost-sharing reductions, the enrollees would face much larger deductibles and copayments and would be effectively unable to obtain the health care they need. And without the payments to insurers to cover the required reductions, insurers would be in an unsustainable position. Already, the threat of stopping those payments has led some insurers to raise premiums and other insurers to plan to leave the market, which hurts individuals and costs the federal government more money in the end. The administration should immediately and unambiguously state that it will continue the payments for cost-sharing reductions specified in the ACA, and the Congress should pass legislation to ensure that happens. Second, the penalty for not buying health insurance must continue. If one could wait to buy insurance until one needed health care, some people would naturally choose to wait. But then it would no longer truly be insurance, which occurs when protection is bought by a large group of people, some of whom end up needing help and some of whom do not. Imagine what would happen to auto insurance premiums if one could wait to buy auto insurance until after one had had the accident and needed the repairs. Similarly, allowing people to wait to buy health insurance until they need health care would increase premiums for everyone else. The administration should immediately and unambiguously state that it will continue to enforce the mandate to buy health insurance specified in the ACA, and the Congress should make sure that happens. Third, the marketplaces must continue to be administered in ways that encourage people to buy insurance rather than discourage them. That includes advertising and outreach, so people learn about the options they have. It includes customer service, so people who call with questions can get answers. It includes an open enrollment period that is sufficient for people to collect information and make decisions. The administration should immediately and unambiguously state that it will administer the marketplaces in ways that encourage rather than discourage enrollment, and the Congress should make sure that happens. These 3 steps do not represent a complete list of important actions. For example, restoring reinsurance, which was in place between 2014 and 2016, would help the market tremendously, as would tweaks to the subsidy formula and other steps that my other panelists will discuss. I want to conclude by emphasizing that the subsidies and market rules enacted in the Affordable Care Act have significantly increased the number of Americans who have health insurance through both Medicaid and the new marketplaces for private health insurance. Repealing those subsidies and rules, with or without the totally inadequate replacement provisions in some of the bills, would make healthcare unaffordable for tens of millions of Americans of modest means who can afford care today. That would be a terrible step backward for our country. But even without repealing the Affordable Care Act, destabilizing the private health insurance market, as the Trump administration is currently trying to do, would hurt millions of Americans. I urge the Congress to prevent this damage. Thank you.
Thank you very much, Mr. Elbendorf. Ms. Miller?
Thank you. Good afternoon, Leader Pelosi, members of the committee. Thank you so much for the opportunity to be here today. I applaud the committee for holding this hearing to highlight the urgency of the need for certainty and stability as we strive to make our healthcare system and our health insurance market work for all of those who need it. While the fate of the current congressional proposals to repeal or replace the ACA is unclear, that does not mean that there are not things that need to be done to move our markets to stability, things that I believe can be done in a thoughtful and bipartisan way, and things that need to be done now. I'm not going to sit here today and tell you that the ACA is perfect. It's not. But the narrative that the Republicans in Washington are pushing, that the ACA is failing and unless Congress takes action, it will implode, is just simply false. Millions of Americans have benefited from the ACA, and the employer markets, where the majority of people get their insurance, have actually seen a moderation of costs since passage of the ACA. Now, there are legitimate issues in the individual market, but this is a small market, generally covering about 5% of the population. And this is also the market that's heavily subsidized by the ACA. I generally hear from about the 1% to 2% of Pennsylvanians in this market who don't have access to financial assistance. It's that very small population that the market may not be serving as well as it could. The individual market in Pennsylvania is not collapsing, but it's on a solid path to stabilization, and it will not implode unless the federal government takes adverse action, like refusing payment for cost-sharing reductions that would cause it to implode. I believe we need to make targeted, common-sense changes that will improve the ACA and make it work better for the people that it's not working perfectly for today. With that context, I want to offer a few thoughts on issues that we currently face, how the current congressional proposals will impact these problems, and what a reasonable bipartisan solution that would improve the ACA for all could look like. I mentioned that our individual market is stabilizing. That's what I've been hearing from our insurers this year, and their proposed rate increases, which average 8.8%, are further evidence that our market is on a path to stabilizing. And while I'm pleased about this, that stability is on very fragile ground because of all the uncertainty here in Washington. We quantified this uncertainty as part of our rate review process. Insurers told us that if CSRs are not paid, our statewide average increase would be 20% instead of the 8.8%. If the individual mandate is not enforced, the average increase would be 23%. And if both of these things happened, we would be looking at increases of 36% on average statewide. And that's assuming that our carriers decided to stay in the market. I cannot stress enough how difficult this uncertainty is on our insurers. If you asked me what single most important step the federal government could take to stabilize the markets is, the answer is easy. Commit to paying the CSR payments on an ongoing basis and commit to it now. And rather than repealing the individual mandate like congressional proposals would do or failing to enforce it, we need to strengthen it. I know the mandate is not popular, but it is critical to adequately incentivize everyone in the market, especially the young and the healthy. That's how we get to stable and even lower premiums for everyone. We get a balanced risk pool with those who need coverage as well as the young and healthy. Another way we could work to stabilize markets and premiums is to find a way to bring back the successful reinsurance program. This program mitigated the impact of extremely high patients and claims and was estimated to reduce consumers' premiums in the first year of the program by 10 to 14%. This is an area ripe for bipartisan action. Republicans recognize the value of this program. Both congressional proposals allocated funding for a national reinsurance program. Such a program, in the context of a careful bipartisan plan, could be an effective way to scale back the premiums that we currently see. I would be remiss if I didn't say something about the cost of health care. We need to have a serious national conversation about how we can moderate the unsustainable growth in healthcare costs, especially in areas experiencing astronomical growth in costs like we see with pharmaceutical costs today. Many of us are looking for solutions at the state level, but these are national problems that merit a national solution. The health reform debate has been, without question, partisan, but the goals that we're trying to achieve are not. And recognizing the real problems that exist in our healthcare system shouldn't be either. My hope is that we can begin talking about healthcare differently as a nation. We all want Americans to have access to healthcare that they need, and we want them to be able to afford it. We all want them to have choices, and that means supporting a competitive health insurance marketplace that can provide those choices. Let's start by recognizing where consumers may not have that access or affordability today and look for solutions to address those problems. In the short term, let's continue paying CSRs, robustly enforce, if not strengthen, the individual mandate, and look to put in place a reinsurance program to stabilize and even moderate premiums for consumers. In the long term, we need to look for ways to moderate the growth of healthcare costs to ensure that we have a healthcare system that will meet the needs of those who need it now, as well as the needs of those who need it in the future. I sincerely hope that we can move away from the drastic proposals that would jeopardize the health and financial security of millions of Americans and focus immediately on solving real problems with common sense solutions like these. Thank you.
Thank you very, very much. Mr. Cohen, if you will bear with us, we are going to recess for the moment, go upstairs and vote. There are 2 votes, and I'm looking at all of my colleagues. There's requirement to come back. resume the hearing this afternoon and wanted to ask Mr. Cohen if you will provide your testimony. Thank you very much. And thank you to our colleagues, some who have come back, some who are new additions, and I'm sure we'll get some other folks who are coming as well. Thank you, Mr. Cohen.
Leader Pelosi, Chair DeLauro, members of the committee, thank you very much for the opportunity to be here today. You know, I've had the privilege of having served as a state insurance regulator under Congressman Garamendi and serving in the Obama administration implementing the Affordable Care Act, and now working at Blue Shield of California, a not-for-profit health insurer that is the largest has the largest membership on our exchange. And there are three things that I would like to share with you today. Number one, the time is now. Number two, what needs to happen. And number three, why it matters. So the time is now to take steps that will lower premiums and out-of-pocket costs for millions of Americans. Rates are being locked in. If the goal is to lower premiums, deductibles, and copays, then the time to act is now. Now, I've heard it said recently that health care is complicated. But actually, what needs to be done now is not complicated. Fund CSR payments, establish a premium stabilization fund, such as the reinsurance program that existed in the Affordable Care Act for the first 3 years and which exists today in Medicare Part D, enforce the individual mandate, and invest in outreach and education so that people know what benefits are available to them and have the help they need in order to sign up. These things should not be controversial. Everyone should want people to sign up because the more people who are healthy who sign up for insurance, the lower premiums are for everyone. And as we've seen, getting in-person help is critical for people to sign up for insurance, particularly for the many who never had private insurance before. I hear some people say that what they want to do is get more people off of Medicaid and onto private insurance plans. If that's what you want, you need to make a market that is competitive and that will be affordable for people in order to achieve that goal. Now, why it matters. Some people argue that risk mitigation programs like reinsurance and risk corridors are a bailout to insurers. They seem to forget that these same programs in Medicare Part D were the blueprint for the Affordable Care Act. When people claim to be concerned about areas of the country that have no insurers offering products in the exchange, they should consider that one reason for that is that no one wants to be the only insurer who has to cover the few extremely high-cost individuals who account for so much of the cost of health care. That was the problem in Iowa, where it was one person whose annual cost exceeded $1 million that led to insurers leaving certain portions of that market. As for cost-sharing reductions, they are not a bailout. They are a benefit that reduces the out-of-pocket costs, the deductibles, copays, and coinsurance for the lowest income people in the exchange plans. The law requires that insurers provide this benefit. All we are asking is that we be repaid for the cost of providing this benefit that the law requires us to offer. Think if a manufacturer were to offer consumers a 10% discount at the retailer in the cost of a product. The retailer would then turn to the manufacturer and say, okay, you now need to pay me the 10% that I gave up when the person came in to buy the product. If the manufacturer then said, but I'm not going to bail you out, would that be a reasonable response? No. And that's the situation we have here. We are required to provide that benefit to people to reduce their cost of care and make it possible for them to go to the doctor. The Congress should fulfill its responsibility to make sure that we get repaid that money. And lastly, as my other panelists have said, it is important that we move from the conversation that we've been having for the last 7 years over are we going to cover everybody and how we're going to pay for it, to how we're going to address the cost of health care. The reason why health care is expensive in America is because of the unit cost of health care. That's the reason. And we need to start thinking about how we're going to grapple that. And the more time we spend fighting over these issues that are consuming our time today, the harder it's going to be to get to that discussion. Thank you again.
Wonderful. underlying common purpose and solutions with our panelists today. And with that, let me ask my colleague and co-chair of the Steering and Policy Committee to make his comments, and then we will proceed to ranking members.
Thank you, Chair DeLauro, and thank you, Leader Pelosi, for convening us today. I think we are demonstrating to the American people that while the public waits for what the Senate will do, and it looks like their intent is to take away health care from millions of people and make it more expensive and put anxiety into so many families' homes, we are putting forward ideas, many ideas that are actually the ideas that Republicans have put forward as to what they would do during the 2 years if there was a delay on the repeal of the Affordable Care Act. So the idea is to show we are working and that there's actually consensus if they want to come to the table to work with us to strengthen the Affordable Care Act. I just want to mention that I also have had the opportunity to chair a group called Future Forum. It is our 27 youngest House Democratic members. And when we're not working as the IT help desk here in Congress, we are going across the country. We've gone to 40 cities and have met with thousands of young people. And the stories we hear from them is that the Affordable Care Act during these uncertain times has extended to them the certainty and the ability to not have to worry about where they'll get their health insurance. So many of them take temporary jobs, or they take jobs that don't necessarily have portable benefits, but right now they have the portable benefit of the Affordable Care Act. And so this truly has been, I think, a conversation that has moved forward because of people and their voices, and they're being heard today, and we look forward to continuing to hear from you. I want to just also recognize who is leading this effort for House Democrats, and they are our four ranking members who have jurisdiction over the Affordable Care Act, and they are, three of them are here. Richie Neal from Ways and Means is not, but we have Frank Pallone, John Yarmouth, and Bobby Scott, and I'm going to yield to ranking member Frank Pallone from the Energy and Commerce Committee.
Thank you, Chairman, and thank you for convening this hearing. And I have to say, the three witnesses are just wonderful. In my opinion, just because you're so practically oriented, looking at what actually happens out there, which oftentimes we don't hear those kinds of voices. All of you talked about the uncertainty in the market. Obviously, what we would like to see is the Republican effort to repeal cease, the effort to sabotage the ACA, which I guess the president has been leading, to cease, and work with us to try to make improvements. I think both Mr. Elmendorf and Ms. Miller specifically mentioned how the uncertainty is playing out with rate increases. And I often say that in my home state, the rate increase that Horizon, which has 70% of the market, has proposed is like almost 25%, but only 8% of that is actually health costs. The rest is uncertainty over the mandate, uncertainty over the CSRs. I want to ask two things. One is, Mr. Elmendorf, if you can explain what would happen if the president decided to unilaterally cut off funds for CSRs. How would this impact the individual market across the country?
Cutting off the payments to insurers for cost-sharing reductions would wreak havoc in the individual health insurance market. Insurers would lose a lot of money because they're required to offer these reductions to lower-income enrollees, but they would not get the payments for that. They would lose a lot of money. They would hike up premiums and flee the markets. And we see some of that happening already just over the anxiety, the uncertainty, and if they actually came to pass, a lot of people would lose health insurance.
Exactly what's happening in New Jersey with Horizon, and that's why we have to make sure that that doesn't happen. The second thing, Ms. Miller, can you explain how this reinsurance works? And, you know, Republicans say it's a bailout. If you would just describe that briefly and why it's not a bailout, or what your opinion is on that.
Thank you for the question. So there were three premium stabilization programs that were part of the Affordable Care Act. Risk corridors was one, reinsurance was another, and risk adjustment was the third. And two of those three were temporary programs, and the reinsurance program was one of those temporary programs. And it was really designed to help insurers cover the very high cost enrollees. So it helps reimburse insurance companies when they're covering someone that has a lot of healthcare costs. And that in turn, what we've seen is that in turn lowers everybody's premiums. And of course helps probably keep companies in the market that may not stay in the market otherwise. In the first year of the program, the Academy of Actuaries put out a document that I believe was included in your materials that talked about the impact of that program on premiums in year one, which was, I think, between 10 and 14%. We saw, even in the out years, premium impacts of between 4 and 7% most recently. So that's a program that really can impact premiums. And I think that's one of the things that all of us, on the regulator side in particular, but I think all of us can agree, if we can do anything to reduce premiums, we should be doing it. And that's an area that's got bipartisan support. So it's
Well,
right for
thank
that.
you very much. And I should mention that as the four ranking members and our leader Pelosi, we had a press conference last week, and we really stressed both the cost sharing initiative and the reinsurance as ways that we can improve and work on a bipartisan basis to make a difference with the Affordable Care Act. Thank you, Mr. Chairman.
Thank you, Ranking Member Pallone. And now going to hear from John Yarmouth, Ranking Member of the Budget Committee. Actually, so we'll go to Bobby Scott.
Thank you, and I thank you, John, for letting me go. I have a hearing at 2 o'clock that I'm convening, so I appreciate your courtesy. The Affordable Care Act made a lot of progress, but it didn't solve all the problems. But whatever anybody thinks about the Affordable Care Act, we ought to recognize if we're going to do something, it ought to be an improvement and not making things worse. We should be lowering costs, we should be insuring more people, and we should be improving the quality of insurance, and we can do that if we work together, but we're not going to do that if we're taking money off the table in reducing Medicaid. If you're spending less money on subsidies, you can't cover more people with less money. And so we want to make sure that we're going forward, and the leader has indicated any number of times that the Democratic members of the House and Chuck Schumer in the Senate, Democratic members of the Senate, are willing to work together, but we will not work together to help things go backwards. I'd like to ask any of the witnesses to comment on the stability of the program. The CBO indicated that the present insurance is stable if you don't mess it up. You've mentioned the havoc that would be wreaked with the cost sharing reductions, the failure to enforce the mandate and what that would do. The association plans have also been mentioned as a possibility. And could you mention how they are problematic and what the CBO was talking about when they said that if the repeal without a replace went through, that 75% of the country would live in an area where no insurance company wanted to participate in the marketplace?
Congressman Scott, the Congressional Budget Office and a number of other organizations that have studied the evidence about the marketplaces have concluded that under the policies in place before the current administration took office, the marketplaces would be stable in most parts of the country for years to come. The problems now are coming importantly from the uncertainty created by this administration's actions and by the legislation moving through the Congress. And if the administration and Congress don't make the payments for cost-sharing reductions, then insurers will flee the marketplaces and they'll hike up premiums, and that will not be to the benefit of the American people.
And so, Congressman, California, we've been fortunate that we have a state exchange. It's been functioning well. We do have a competitive market. No one likes to see rate increases, but the rate increases we have seen over the course of the time since the program began in 2014 have been reasonable and in line with the increased cost of medical care. What we're seeing now, as others have pointed out, we've been directed to submit 2 sets of rates for 2018. One, assuming that things continue, cost-sharing reductions are paid, the mandate is enforced, and one, assuming that those things don't happen. And we have about a little less than a month now before we need to lock those rates down and inform our customers what they're going to be paying for 2018. And as of now, with the uncertainty, they're going to be paying more. And when it costs more, fewer people sign up, fewer healthy people sign up, and the risk pool gets worse and worse. So you end up in one of those, potentially in one of those spirals. You mentioned the Association of Health Plans just briefly. They would essentially return us to a time before the Affordable Care Act when many small employers either could not get coverage for their employees or it was too expensive, because if they even had one sick person who worked for them, they would be charged more. And so with these associations, as it is now, you can't do that. The whole market is one risk pool, and so you can't charge more depending on the health status of the small employees' workforce. But under the association plans, you could put together groups of healthy young people and charge them at one rate, and that would inevitably result in other employers that have older workers or sick workers being charged more.
Can I just make one statement? So when you think about the premium stabilization programs that we talked about, two of those three programs were essentially 3-year temporary programs. So I think the people who drafted the ACA understood that there was going to be some market instability because you were changing all the rules and everything was new in 2014. So we're now in that 4th year. We had 2014, 15, 16, and what I've seen in talking to our companies, I work very closely with the 5 remaining companies in our exchange. And last year, I had to convince some of them to stay in the market because they weren't sure what things were going to look like. They weren't seeing things turn around. But the interesting thing to me was what changed in 2017. As soon as I had started having conversations with our insurers at the beginning of this year, they indicated that their 2017 early experience was getting better and that they were feeling very much like the market was stabilizing. But the only concern that all of them said over and over was, the biggest concern we have is what's happening in Washington, D.C. If you could take that uncertainty of everything happening down there off the plate, we feel really good about our market, and it's heading in the right direction. And the 8.8% average statewide increases we saw filed were sort of confirmed that exactly was happening. But all of what's happening down here is just kind of the big caveat to that.
Thank you. And we'll turn to our ranking member of the Budget Committee, John Yarmouth.
Thank you, Mr. Co-Chairman, and thanks to the Chair DeLauro as well and the Leader Pelosi. Thanks to the witnesses. I appreciate this. This is something that many of us have been involved with now for going on 8 years, and it's getting a little old. I mean, I don't think we're ever going to be finished with it, but we continue to work. You know, one of the things that intrigues me about this debate is that we often have a lot of discussion from the Republicans saying that the solution is a free market approach to health care, and that the problem with much of the ACA is that we don't have enough competition in many of the counties. And Paul Ryan often says a third of all the counties in the United States only have one insurer, and we know a few counties have none. But I come from a state with counties like Robertson County, which has 2,300 people, and Elsley County, which has 4,700 people. And when you assume that a county of that size is going to have somewhere near the national average, in Kentucky it's a little bit higher on Medicaid of 25 to 30%, and then you take a percentage that will have employer-based insurance, and you may have a county that has potential customers of 500 or 1,000 people. And so the idea that there's a way to create competition among insurers in a market like that is basically unrealistic. Isn't that the experience that you have in Pennsylvania?
Well, I'll tell you, it's interesting. The issue of competition, I know since the beginning of this debate several years ago, there's been this desire to have more competition on the insurance company side. What I've experienced, I was the insurance regulator in Oregon before I was the regulator in Pennsylvania, and both states had fairly competitive health insurance markets. But on the provider side, there wasn't as much competition. And I'll tell you, if you look at premiums, provider competition, I think, has a lot more to do with premiums than insurance company competition. We have some areas in Pennsylvania, the areas where we have fewer, like the areas that are covered by one insurance company. Those are some of the lowest prices in the state. Some of the areas where we have more insurance companies, in some areas we have 3 insurance companies, those are actually the higher premium areas. And in many cases, they're in rural areas. So again, if you look at the provider competition, my biggest fear as we try to address the costs of healthcare is really provider competition. And where that doesn't exist, you can see it in the prices. And insurer competition is not nearly as important when it comes to prices.
And in fact, we did, in the ACA, there was kind of a government option for competition, which was the co-op program, which Kentucky established and was actually having a very successful run at it until the Congress essentially defunded the subsidies. So I have two questions real quickly. One is that it seems to me that both the House Republican bill and the Senate bills admit essentially that there is no way to create a viable individual market without government involvement, either through tax subsidies, through CSR, through reinsurance, through high-risk pools in the case of the House bill. And that's something that I think they had never been willing to admit, but they implicitly admitted it in their legislation. The other question I have is, and I've been saying it, so I'm just asking particularly Mr. Elmendorf, because I know he's studied these other bills, is I've been saying that under any of the Republican-offered alternatives, there's no way they can guarantee that any single American citizen will have better coverage than they do now. Mr. Elmendorf, would you say that's a fair statement?
So, Congressman, I think you are just right to say that to have effective competition in a private health insurance market requires a set of rules that insurers and families have to abide by, because health insurance is not a commodity like every other commodity. And I think you're also right to say that the bills Republicans have advanced would hurt the access to health care for tens of millions of Americans, and that would be a tremendous step backward for our country.
If I can add just one point, Congressman, on the competition issue, people who are talking about wanting to have competition need to remember that before the Affordable Care Act, there was no health insurance market in the individual market for the millions and millions of people who had a pre-existing condition. There was no market at all. So when we talk about wanting to have a competitive market, we need to keep that in mind. We have created a market through the Affordable Care Act.
Thank you. I appreciate that. Thank you, Mr. Chairman.
Yeah, thank you, Ranking Member. And we're going to turn now to our Assistant Leader, Jim Clyburn of South Carolina.
Thank you very much, Mr. Chairman, and thank Madam Leader and Chair DeLauro for convening this hearing. I'm extremely impressed with these presentations here today. I'm a little used to hearing from Dr. Elmendorf, having been a part of that super committee and other things that again, it's a great deal of admiration and respect for you, and I thank you so much for your testimony here today. I'm particularly interested in this whole issue of certainty in the marketplace, in people's homes, in people's lives. It seems to me that that's becoming a watchword for all of us in many, many different areas. Now, some of the things, in one particular thing, this lawsuit, this House versus Price lawsuit that continues to exist. Either one of you to tell me something about what that lawsuit is doing to certainty. Or maybe all three of you.
Well, I'll start and just say that this is the litigation on CSRs, I think.
Yes,
is what
on
you're talking about.
CSRs, yes.
So last year, after we had finalized, or at least we thought we had finalized rates for our companies, I had phone calls from a couple of them indicating that even though we thought we'd gotten to a kind of an agreement on the rates, they called and said they're not sure they wanted to continue in the market. And that's a big problem for regulators. So I actually went out and sat down with some of the companies, and the biggest issues they raised, one was enforcement of special enrollment periods, which I think, a fair criticism of the last administration is that they could have done more to enforce special enrollment periods, and that would have been helpful. But the second one was the litigation. And at the time, this was back in September, so this was before the election. Even having that case out there, they had dollar figures that they could put on that case and what it meant to them. And those two issues in particular, enforcement of the special enrollment periods and that litigation, those were two of the big issues and reasons why they were really struggling to figure out if they wanted to stay in the market. And I had to bring folks from the Obama administration at the time down to Pennsylvania, or up to Pennsylvania, and we sat down together with some of our carriers to say, what can we do from the state side and from the federal side to keep you in this market and to make it a more attractive market? But CSRs was at the top of that list of big concerns.
And Congressman, I must be a very simple-minded person, but the House leadership that brought that case believed that an appropriation was needed to fund this money. They went to court. They won. Okay? The court said an appropriation is needed to fund this money. Do an appropriation. It's very simple. We have to provide this benefit. The insurance industry, it's worth billions of dollars to the insurance industry nationwide. They won their case. They made their point. Now it's their obligation to appropriate the money.
Now, I would just add, Congressman, that the consequences of uncertainty show why a strategy of repeal and delay would be such a disaster for the country, because there's a lot of uncertainty already created by the federal government's policies. And if on top of that, the government said, well, we're going to take the whole thing away in a few years and do something we don't know what, that would have a terribly damaging effect.
So you're saying if the Senate were to come up with the legislation that it is discussing, that is to pass something to repeal, delay its implementation out to 2019, you're saying this would have even a greater adverse impact?
Yes, absolutely.
Well, thank you.
Is to recognize 4 members at a time, and you state your questions, and then we will have answers from our panelists. And on the first go round, we want Representative Ruiz, Representative Mike Thompson, Representative Scott Peters, and Representative Jan Schakowsky. Representative Ruiz?
Thank you. Thank you for holding this hearing. It's a special treat to have all of you 3 on the panel. I'll tell you why. I'm personally connected to all of you. I'm an alumni and a graduate of the Harvard Kennedy School of Government. I trained at the University of Pittsburgh in Pennsylvania in emergency medicine. And I grew up and I live and my heart's always in California. So thank you all for being here. I'm an emergency medicine doctor. I take care of complex patients that have different multi-organ trauma, for example, with different needs and different urgencies. And we always have a method of approaching all of these complex situations. A simple recipe here would be: first, do no harm; 2, stabilize the market; 3, take care of the patients. And you have talked about how there is active decisions that the Trump administration is currently doing that is harming the marketplace, that's harming patients, and that's an outrage and a shame, because the people that are suffering are the American people, are the patients, the people that need health care. Second is we need to stabilize the market, and I've introduced a bill called the Marketplace Certainty Act that will do just that. It will permanently fund CSRs, and it will increase the eligibility to receive those co-pays and deductibles subsidies for patients up to 400% federal poverty level, which for an individual is about $40,000, $46,000. So the quote of letting Obamacare fail is very misleading, and that's one of the more frustrating thing about this discourse, and you've all pegged it, hit it right on the head of the nail. It's politically motivated. It's a way to hurt people in order to force people to want to swallow their placebo, or actually their poison. So I know this question was asked of Mr. Allendorf. I want to ask Mr. Cohen. In your testimony, you highlight the difference cost-sharing subsidies make for your members. Can you explain more what they have to lose if this instability occurs? And I also want you to emphasize the time urgency that we have here. I don't think a lot of people understand that right now insurance companies are deciding whether they're going to stay in the market or they're going to leave the market, what's the price that they're going to hold, and all of them are pointing to the uncertainty. So can you elaborate on that time frame and on the urgency of needing to act right now?
Thank you, Congressman. I can. So on our timeline, once we get to the middle of August, that's when our rates get locked down. They get input into our system. It takes a little bit of time to get that done. When I was in the Obama administration, I had the very painful experience of knowing what happens when you haven't got your data locked down and your IT working properly. So you've got to get that done in time for open enrollment in November. And we need to inform our current members what their rates are going to be for the future, because they're going to be renewing, and they may have the opportunity to shop around, pick a different plan. So we have to get those rates locked down literally in less than a month. So right now we're dealing with the situation where we have to be looking at, are we going to be getting that cost-sharing reduction funding or are we not? And we're not hearing about an appropriation from Congress, and we are hearing about statements from the President and others that that funding may not be there. So we have to take into consideration the fact that we may not get that funding. If we don't, then we have to increase rates for everybody. It's not just for the people who get that benefit, but it's for everybody's going to pay more to spread that cost among our members. And nobody should want that. Nobody should want people to have to pay more. When the question of what that benefit is worth to people, it is literally the ability to actually go to a doctor and get care or not. If you're a lower income person and you have a plan with a deductible of $3,000, that might as well be $1 million. And the whole point of the cost sharing reduction is it reduces the cost of that deductible and that copay that you have to pay each time you go to the doctor to a level that is affordable for people and that they can actually get care.
If you were to pick one thing we can do right now, would it be the cost-sharing reduction?
That's the number one issue for today, yes.
For today?
Yes.
It's to stop the bleeding in an open femoral fracture that will save the patient's life, right?
Correct.
Okay.
Mr. Thompson.
Thank you, Madam Chair. Thanks to all the witnesses for being here, for your fantastic testimony. I had some questions that I had planned to ask, and I sat down when we first convened, and over my my device, I got two messages that came in, two press reports. One that said, if the Affordable Care Act is repealed, we can count on losing 1 million jobs right away. And then the second one was talking about this skinny bill option that the Senate Republicans are talking about doing, where they would eliminate the mandate and the device tax. And I know, Mr. Almendorf, you've got great experience with CBO, and CBO has already said that if they do some of the things they're talking about, it's going to cost us somewhere between 22 million and 32 million jobs. If they do this skinny bill, what would CBO's estimates look like if you consider that and the 1 million job loss?
Well, Congressman, as you know, former CBO directors do not carry around in their heads the ability to do all of the analysis that the team of people
give us a rough idea
at CBO
of how many
do.
million people would lose health care.
All I can really say, Congressman, is that the mandate to buy health insurance is critically important because the essence of insurance is that a set of people sign up. This is true for auto insurance, for homeowners insurance, for health insurance. A set of people sign up not knowing who will have the car accident, whose house will be hit by lightning, who will end up being diagnosed with a serious disease. And by pooling those risks, we can each pay the average cost of what will happen rather than having some people just do totally fine, but other people be completely hammered by a health problem for which care exists, but which they cannot afford. So the essence of insurance is that people sign up ahead of time. Those of us with employer-sponsored health insurance, many Americans, are thus in a pool automatically. The genius of the Affordable Care Act was to create a similar pooling mechanism for people who could not get that kind of insurance through their employer. As Congressman Swalwell pointed out, we need in this country more portable benefits, not less.
Thank you, Mr. Cohen. My colleague Anna Eshoo and I have legislation that would provide an adjustment for the premium tax credit depending upon the cost of living. And both of us represent a high cost of living area, and a lot of folks are squeezed out of the market because of that. Would that be a help?
I think it would be. I think it's very important that the premium tax credit reflect what it actually costs to buy health care in a particular location. So I think that would be a helpful thing to look at.
Thank you. Thank you, Madam Chair.
Mr. Peters.
Thank you, Madam Chair. I'm very discouraged that in the House process, in the Energy and Commerce Committee, they didn't have hearings. So it's nice to actually have a hearing where you can ask questions and get responses. As a
And,
consequence,
and they are nicer questions,
yeah,
so that's good.
probably true. As a consequence of not having hearing, though, a few of us, led by Mr. Schrader and Mr. Welsh, decided to go have our own hearings. We had meetings with Peter Lee of Covered California. We had met with AHIP, the American Health Insurance Plan. We met with some academics. And we heard the same things about what to do to stabilize the market, which we've already discussed, which is CSR certainty, reestablishment of reinsurance, and the mandate. The discouraging thing now about the mandate is that there seems to be a real move to get rid of it. So I wanted to ask you, do you see a second option for dealing with getting younger people in? Particularly one is how effective is requiring advertising about the availability of health insurance, which I understand California spent more on advertising than all of the federal exchange states combined. Two is, what about the concept of auto enrollment of young people in a plan that would allow insurance companies to get them in and to upsell? If we had to move off I don't think you get any back talk about the mandate here, but if we were able to move off of that, would those other options be effective, and to what extent?
So I think that's a conversation that we need to have if, in fact, we are going to move off the mandate. I think everybody here believes the mandate is very important. But if we are going to move off the mandate, then we need to look at various ways of providing incentives to people to enroll as opposed to disincentives for people to not enroll. And among the ones that you mentioned, I think are all things that we need to look at.
Dr. Elmendorf, to you.
So I agree very much with that. Advertising is important, and auto enrollment can be very important. We have a lot of evidence now in various contexts of the value of having a default to be in something and have to then consciously decide to come out of it, rather than by default you're just sitting doing your own thing and have to think about it and learn to go in. But I can't offhand quantify what the effects of advertising or certain sorts of auto enrollment rules would be, but I'm all for them, and they can be complements to a mandate as well. They don't have to be just a substitute if a mandate is taken away. These can be important steps to go along with the mandate to try to increase health insurance even beyond where it is today.
Thank you. And I hope they don't cut the CBO so much that they can't do the calculation that you don't have in your head.
Yes, Congressman. I must say, if I can, I think the attacks on the Congressional Budget Office, on its integrity, on the value of its work for the Congress, and potentially on its budget, are terribly short-sighted by any member of the United States Congress. The CBO was created to give the Congress a source of information of its own in making policy. To take that away, whatever one thinks of a particular estimate, is really very damaging to the ability of the Congress to make informed policy in the years ahead. And that is why I and all of the other former directors wrote and signed this letter last week, reminding the Congress and the leaders of the Congress about the value of CBO.
Thank you for doing that. Thank you, Madam Chair.
Thank you for your leadership, Mr. Elmendorf. Ms. Schakowsky.
So, Ms. Miller, I'm trying to get a handle on what you were saying, that the problems, certainly in my office that I see, almost entirely have to do with the individual market. And you gave us some percentages. What was it, about 5% of Pennsylvanians are in the individual market? What percent of the problems that you're seeing with the ACA are in that market?
Thanks for that question, because I think it's a good one. And I think from where I sit, really all of the people I hear from that are not 100% excited about the Affordable Care Act, they're in the individual market. And again, I think it's really helpful to understand what we're talking about there. So the individual market in Pennsylvania, and I think it's similar across states, is about 5% of the population.
It's only about 3% in Illinois, actually.
Okay, so it's a very small market to begin with. It is an important market, obviously, because these are families buying insurance on their own. They don't get it through their employer. But it's also important to remember this is where most people in this market are getting financial assistance, at least in Pennsylvania. So in Pennsylvania, on our exchange, which is not our entire individual market, but it's a good portion of it, 80% of the people in the exchange have access and are getting subsidies. And over 50% are getting the cost-sharing reductions, so that policy that allows them to pay less when they go to access care.
So 80% of the 5% are getting help?
Not entirely, because part of our market is outside the exchange, and of course no one outside the exchange is getting access to subsidies. So we have, the numbers always change, over 500,000 in our market, and about 400,000 or a little over 400,000 are on the exchange. And it's 80% of that a little over 400,000 that get the subsidies and the CSRs.
So when we're talking about improvements now in insurance, are we mainly focusing on a relatively small percentage of people who actually have had trouble with with Obamacare, Mr. Cohen?
Yes, that's right.
So I think that's missing to a lot of people because, we line up our stories about people who have been helped by the ACA, and they line up people who have been hurt by it. And I think Donald Trump had some of those people behind him yesterday or the day before. And yet there's no perspective on who we're really talking about and the people that are actually helped. I think that's really important. Let me just, the sabotage issue is really, really worrisome to me. I wonder in the brief time that I have left if any of you could comment on what you think we can do to stop the sabotage. Any of you?
Well, I think the most important step, as we've agreed, is that the payments to insurers for cost-sharing reductions need to continue, and that needs to be made clear to insurers immediately. I mean, yesterday or the day before, not tomorrow, not next month, not next year. And that is where the biggest immediate danger to the market is, because if insurers don't get paid for benefits they're required by law to provide, then they will leave the market and they will push up premiums. And that is the most immediate form of sabotage.
And will the insurance companies, join the blue? And will we get their support if we do that? If they understand the difference that it would make to them?
Oh, I think absolutely. I mean, I think, for at least speaking for my company and for Blue Cross Blue Shield companies, our mission is to serve the people, in the states where we are, and that's what we want to be doing, and that's what those companies have been doing, and it's because of a lot of this uncertainty that people are finding it, asking themselves, is this a market that we can be successful in?
So is the insurance industry going to be our ally against sabotage?
Against sabotage, I believe so, yes.
Thank you, and I yield back.
Thank you, Ms. Schakowsky. We're going to go to Doris Matsui, and then Judy Chu, Matt Cartwright, Sherry Bustos, and then Sheila Jackson-Lee.
Thank you very much, and I really appreciate the panelists being here today. You've all been very articulate. I want to focus in on California, because we have been working with ensuring that the ACA be as successful as possible in California and really planning ahead to figure out how we go through this rough weather in a sense, too. Mr. Cohen, I know that Blue Shield has been a leader in this, and you've been a wonderful player in this here, especially in transforming the health system from paying for volume instead of paying for volume, paying for value. And can you describe, as you move forward, specific efforts that you have been doing, Blue Shield has been doing in the state to achieve these goals, and how we might be able to ensure or bring in other insurance companies to understand that this is a way to move along and be able to save some money, too?
Thank you, Congresswoman. So as you've pointed out, Blue Shield has been a leader in creating what we call accountable care organizations, which are deep partnerships with hospitals and doctors to provide care, to work to a budget, and to share risk, both upside risk and downside risk, so that we all have the same incentive to manage care correctly and to provide good outcomes for people at lower cost. And so that's something that we're very committed to and trying to grow. The more that you all can do here in Congress to encourage that and to encourage that happening in public programs as well as in the employer market would be helpful.
Okay, and I was also wondering, too, that there are, if you look at the cost to consumers, what projects have you worked on to implement that have the most impact on reducing costs? Because I think we're also looking not only with the costs that we have moving forward, but also as we look at the costs of healthcare itself. How do we reduce some of these costs and reduce the impacts on the consumers? And what can we be doing legislatively for that?
So I think there's been a lot of discussion, obviously, recently about the high cost of expensive prescription drugs, and that's been an increasing share of the total cost of health care in the country. And so there are a number of bills that have been promoted here and in the states. In California, for example, we have a bill that's moving forward for transparency on pricing among pharmaceutical companies that would go a long way. Right now, they can raise costs without providing any information on what the basis for those increases are or why they're happening. So that would be helpful.
Thank you. I just wanted to also just bring this up because we first have to deal with the cost-sharing reductions and the reinsurance and marketing and all those types of things. But we can't stop there. We all know that we have to move forward. So part of this is ensuring that everybody understands these are the first things that we have to think about to ensure that the market exists, right? Beyond that, we can't forget about the fact that for this whole system, we have to look at how we reduce costs. So I thank you very much, and I yield back.
Thank you, Ms. Matsui. Now, Judy Chu.
Well, one way to fix the ACA would be to deal with the issue of prescription drugs. Currently, 1 out of every $6 spent on health care is spent on prescription drugs. Medicare spending on the Part D benefit has increased from $46 billion in 2007 to $80 billion in 2015. And studies from the Kaiser Family Foundation have found that there's overwhelming support for allowing the federal government to negotiate with drug companies to get a lower price on medications for people on Medicare. And also they support making it easier for generic drugs to come to market and also requiring drug companies to release information to the public on how they set drug prices. So despite all the Republicans' talk of lowering health care costs for consumers, we've not seen any proposal on dealing with the issue of the skyrocketing cost of prescription drugs. So could any of you describe how dealing with a prescription drug issue could help to fix the ACA?
Congresswoman, you raise important and challenging questions. I'm skeptical, as some other people are, that negotiations by the federal government are the key part of the solution here. And my skepticism comes from the fact that the power that you could have in a negotiation is telling some drug manufacturer, we will not pay for that drug, or we will not pay very much for that drug. But that then can lock some people out of getting access to that drug. So that's a hard sort of negotiation, and I think a hard one, to be honest, for all of you to watch happen from an HHS secretary. So my own view is that it's more about the underpinnings of the market, more about the rules about drugs coming to market, about what has to happen in exchange for federal support for the basic research that leads to some of these drugs and so on. I would focus more in that area.
I think what I would add to that is just that this is the conversation we should be having. We should be talking about how do we actually get at the cost of care. I think when some of the Republicans who are pushing some of the proposals out there today talk about reducing premiums, all they're talking about is shifting the costs onto consumers. They're not talking about reducing the costs at all. It's really just, instead of having insurance companies pay it, we'll have consumers pay it. And a lot of consumers, as we know, won't be able to pay it. But this is exactly the conversation we should be having going forward.
And I agree with that. And I would just say that there are bipartisan common sense ideas out there like the CREATES Act, which would enable patients to have access to generic drugs when patents expire, that Congress should definitely be taking up.
Great. Thank you, Ms. Chu. And now we're going to turn to Matt Cartwright of Pennsylvania.
Well, thank you to the co-chairs and to the leader for putting together this important conversation. And thank you to the panelists for coming. I'm particularly proud of Commissioner Miller. In fact, you blew my cover, Commissioner. My fellow members up here were saying, wow, she is so impressive and knowledgeable. And I said, well, we're all like that in Pennsylvania. And then you said you're from Oregon. And Congressman Welch turned to me and said, busted. I want to continue this discussion that Representative Chu started about the cost of care. I mean, we can talk about 3 or 5% our individual market. We can talk about 150 million Americans are covered by employer-sponsored coverage. But I'm hearing from the employers, their premiums are going up. You've said out loud, we have to have the conversation. We've talked about pharmaceuticals, but I want to talk about healthcare in general. Let's not just have a conversation about how we have to have a conversation. You all have been thinking about this, and particularly you, Commissioner Miller, I want to push you on that. You've been thinking about what steps can be taken in the healthcare community to reduce the astronomically rising level of costs. What are you hearing? What are the ideas?
Thank you for that question. I feel like I planted that. So Governor Wolf in Pennsylvania has had a health innovation plan that we've been working on for the last few years. We've brought together all the stakeholders and really asked this question: what can we do to try to address the costs of care? And from the insurance department's perspective, we've been leading some of the price and quality transparency work. So we've been looking at things like health literacy. And again, we've got a subgroup that's actually currently meeting with all the stakeholders to say, how do we make sure consumers have the information they need to make educated and informed decisions when they go to get care, so they can get care from the right places, the most cost-effective places with the highest quality. But we've also been having conversations about implementing an all-payer, all-claims database. We've put forward legislation to try to implement what we call an APCD in Pennsylvania, which would give us the data we need to start understanding better where we're paying too much and what we can do about it. We've struggled legislatively to get that through our Pennsylvania Assembly, but we're continuing to work on that because we think that's the starting point. And ultimately, we've also had some subgroups looking at price transparency. How do we get better information out there to consumers? I've got employees who've come to me, and now that we have a deductible in our employee plan, say, I've got to go get a shot that costs me $150 a month. Where do I go to get that where I don't have to pay that? And if we can figure out how to get them the information to do that when they're under their deductible, that saves consumers money. But then when they're not under their deductible, it saves the system money. So we've got to do, and we do not do a very good job of that today. We're trying to work with stakeholders to get better information out there for consumers so they really can make informed decisions. But in addition to payment reform and some of the other things we've talked about, there's a lot of things we can do there. And I thank you for the question, because this is the conversation we need to be having, and this should be our focus going forward.
Thank you. Yield back.
Thank you, Mr. Cartwright. Next is Sherry Bustos of Illinois.
Thank you, Mr. Swalwell. I represent a district that is mostly rural on the northwestern corner of the state of Illinois. And Commissioner Miller, I know earlier that you said that competition does not necessarily lead to lower premiums. So I'm just wondering, when you think about rural areas and these bare counties, what are the answers? And I'd like to hear from each one of you. It's a really big concern of mine, and I want to be able to come up with some answers and figure out how we can help rural areas, not just in the state of Illinois, but throughout the country.
Well, and this may sound really simple, but I mean, in many ways, bare counties are the result of not having companies that want to participate in the market, right? So at the end of the day, I think some of the things we've been talking about today really are the answers to that question. If we can make this a market insurance companies want to participate in, I don't think we have to worry about the bare counties. I think one of the things I've been concerned about for the last several months as this conversation's been happening in D.C. is that right now we don't have any bare counties in Pennsylvania, but I fear that as these conversations continue and the uncertainty continues, as we've been talking about, insurance companies here are getting very close to dates where they have to make decisions about staying in the market. And this uncertainty is what's killing that. So if we can kind of stop the bleeding like we've talked about and make this a market insurance companies want to participate in, I think they'll be there in those rural counties. And I'm sure there are other things we can do to address specifically bare counties. But first and foremost, we just have to stop doing damage. We have to stop not paying risk corridors and not committing to paying CSRs and continuing to undermine this market to make it a market insurance companies just say, okay, I can't be here anymore.
Thank you.
And I would just add, access to care in rural areas is a problem. It was a problem before the Affordable Care Act. It's going to be a problem no matter what happens to the Affordable Care Act and what's taking place here. So we need to think about, what can we do to improve that situation? One idea I want to suggest is we should be making more use of telehealth and telemedicine. The Medicare program makes it extremely difficult to get paid for providing telemedicine services. And it's what people want. People would rather not drive 100 miles to get to the doctor if they could have a video visit that would take care of a lot of their problems. So technology is not the answer to all of our issues, and obviously there are some conditions where you have to be there to, you can't treat a broken leg, on a video call. But there are a lot of things that you can do, particularly in mental health, for example, which is one where access has traditionally been extremely difficult.
Thank you.
I agree with my fellow panelists' comments. I think there's an issue of stabilizing insurance markets, making sure people want to be in those markets. And I think vigorous actions by state insurance commissioners are crucial to that. You told the story about sitting down with the insurers who are thinking of backing out of the market and finding out what could be done to keep them in. And that matters a lot. That's happened in California as well. There's a somewhat separate question, which is how to make sure care is available in rural areas, which is a very long-standing problem, and which the Congress has dealt with through special payments to rural hospitals and many, many other things. And we should continue to work on ways to address that.
All right, thanks very much. I yield back.
Thank you, Ms. Bustos. I will turn to Whip Steny Hoyer.
Thank you very much. I apologize. A lot going on today, but I don't think anything's going on that's more important than your testimony, other than the vote that's now going on in the United States Senate, and hopefully we will prevail there so that we can look, as McConnell said, if they fail, work in a bipartisan way to fix the Affordable Care Act, which I asserted pretty strongly this morning on TV. It's working. And if we'll not destroy it, which is what you were saying and what Doug, I want to thank you for testifying on our previous hearing some months ago. Gary, thank you very much for being here. And Madam Commissioner, thank you for your work. Leader Pelosi, yesterday in our leadership meeting, pointed out that in the McConnell bill, one of the two alternatives, they set forth how to stabilize the market for the next 2 years, because, of course, they're talking about phasing out. And all of the things that you mentioned, they know full well what they're doing, and they know full well how to stabilize the market. And the ACA is working. It's not working in some places. And Gary, as you just pointed out, it wasn't working before the ACA. And we know how to fix that, and it'll be costly because the market, one of the problems is we pretend that the healthcare system is like a free market, like buying, something at Walmart that is cheaper priced than something else. We don't buy our healthcare that way. It's just not rational to think that human beings think that way. But these 4 items that they list, clearly, if we did them, which is one, it would give the insurance company a better ability to price its product and more confidence, and it would give the marketplace more stability. So I thank you for your testimony here today. Questions, we're about to end this hearing. I was very late, and I apologize for that, but I really do appreciate your being here and spending your time here. And, of course, Doug, thank you very much for the service you gave to the CBO. Hopefully it will exist next year. And if it doesn't, the country is going to suffer. But it's such a wonderful group of people who give such honest advice. And as you know, I talk to you as I talk to every CBO director since the time I've been here. Give us the honest answer. We may not like it. It may not be in our political interest, but if it's an honest answer, the American people will be advantaged. And you always did that. And frankly, almost all of your predecessors. I don't have an exception in mind. So all of the predecessors did that as well. And I think your successors have done that, and God bless them.
Thank you very much.
Thank you. No, I'm fine.
Thank you.
To all of our colleagues for being here, and thank you all very, very much for your testimony. It's powerful testimony. I think I've been struck by a couple of things, and obviously what we were trying to do today is to look at stabilizing that insurance market. How do we go about do that? And there's a genuineness about what all of you have said about doing it. And what has struck me is that underlying there are some pieces here that there is common ground that you have, whether it's CSRs or reinsurance, it's the education, it's outreach, and there's some pieces around the edges. You agree long term that prescription drugs have to be dealt with, and that is powerful testimony in this time where people are just it's fake news about how the Affordable Care Act has failed. It's interesting. I noted earlier that we did some looking at common ground amongst Democrats and Republicans on the reinsurance issue. House Republicans, House Democrats, Senate Republicans, Senate Democrats, Republican governors, all for dealing with reinsurance and making that sound. In CSR, again, House Republicans, House Democrats, Senate Republicans, Senate Democrats all believe that the CSR payments should be made. When Secretary Price testified before the Appropriations Committee, he just would not answer any questions with regard to the future of CSR, claiming that it was litigation and he was engaged in it. But I know the payments have been made for June. I don't know whether or not the payments have yet been made for July, but it's critical to the stability of that market. And just what I would just say, it is so enlightening, and this word has got to get out about what can get done about this stability. But I will just tell you that flat out for myself, our colleagues on the other side of the aisle do not want to stabilize the insurance market. You don't have to attest to that. We can't attest to that. Essentially, what they are engaged in is a self-fulfilling prophecy that the Affordable Care Act is a failure. It will implode, and the hypocrisy of it all is that they have no replacement. They have no replacement, and nothing that is going to ensure that the people of this great nation have health insurance that they can afford and that is quality, and everyone is going to be able to share in that effort. We thank you so much for your professionalism and understanding the nuts and bolts of this issue. And we want to get your word out there because you have such standing in this area. Thanks so much for today. Thank you very much.
Can I? Yes, and we'll Ms. Jackson Lee.
Okay. I thought you were saying goodbye.
Well, we are.
Okay. All right. I told her I was coming back. I apologize. Thank you so very much. I had to go to the Rules Committee. Let me try to use the very, very skinny time that I have to thank all of you for being here. I come from Houston, Texas, the Texas Medical Center, which I'm trying to convince the Texas Hospital Association, or not convince, but to have them be more energetic and vocal about what is right for them, not as what is right for Democrats and Republicans. So let me just do a question across the board. And that is, particularly Mr. Cohen, I know you may have stated, but restate it again. All that is going on that pours out of Washington, the word repeal, a skinny bill, numbers, that frightens the market. If we were to continue the subsidies or the elements of the Affordable Care Act, which Mr. Elmendorf gave us good numbers to work with, subsidies, work with rural hospitals, make sure that the Medicaid is strong. I just heard today that we're a $22 trillion economy
There's no reason why we can't find a way to strengthen Medicaid. But anyhow, would we not be in a place where we would not look at numbers like 32 million or 22 million, but we could stabilize this system, work with your health system? We have something called Harris Health. And if the three of you could just add on our way of stabilizing, if the messages here were right messages and we're doing the right thing.
Thank you, Congresswoman Jackson Lee. So in California, the Affordable Care Act is working well. We have reduced our uninsured rate by more than half, from 17% in 2013 to 7.1% this year. A lot of that is due to the Medicaid expansion, and in addition to health care that's being provided by the subsidies. So while there are things that could be done to improve the way it's working today, it's working well. If we can avoid any big obstacles put in our path, I believe it will continue to work well and will continue to serve Californians well.
Mr. Almanoff?
I agree with very much. The marketplaces can be sustained in a stable way if only the Trump administration would carry through with the specifications of payments and other actions under the Affordable Care Act. They are deliberately undermining the marketplaces, I think, to create political support for their opposition to the Affordable Care Act. But that is very short-sighted because millions of Americans are being hurt or will be hurt if they push the marketplaces into a destabilized state. And moreover, Americans' confidence in the private health insurance system will be diminished if the marketplaces falter, which, if anything, is an outcome that the Republicans, who generally support private insurance, should be worried about themselves. So I think this is a damaging and short-sighted policy by the administration. I hope that they change course along the lines we've discussed. I hope the Congress tries to force them to carry through with the provisions of the Affordable Care Act.
Madam? Yes.
And from my perspective, I think as we've talked about today, number one, if we can stop undermining the market and actually work towards stability, I think as Co-Chair Dolores said, we're all on the same page on so many of the things that need to be done. This is not a partisan issue if we really focus on just stabilizing the market. I think one of my biggest frustrations, and I think a lot of us who have been working on this issue with the proposals that are out there, is they don't actually solve a health care or health insurance problem. The president has promised that we were going to have better coverage, it was going to be more affordable, and more people would be covered. And the proposals out there don't do any of those things. They actually take a step back in each of those areas. So if we were actually trying to solve this problem and understood the problem, which is really in the individual market, there are ways to do that we've talked about today if we just actually focused on that.
Let me thank you all, the co-chairs and the leader, for this very astute, very important hearing. And I'd only say there's a vote, I guess, coming up in a couple of hours on the other side of the Congress, or maybe it's going on now. The leader is saying, and I just want to quote Senator Al Franken, this will be probably one of the most, or the most significant vote that they will cast in reframing the life-saving structure that we've given, and that they will take it away. So I hope that vote goes in the way that you all have just articulated today. Let us help the system, as we as Democrats have said, and it's not partisan. Let's work to strengthen it so that we can have more opportunities for Americans to be covered. I thank you very much, and I yield back.
I thank our co-chairs, and I'm going to yield to Mr. Swalwell to close. Congresswoman DeLauro opened, but I want to thank our three guests, Mr. Cohen, Mr. Elmendorf, Commissioner Miller, for your excellent testimony and for the clarity that you presented. Your objectivity in making judgments about what is good, what works, what doesn't work, where we can do better, where we must weigh in, has been very helpful. I started the meeting this morning earlier today by talking about cost to individuals, cost to business, cost to the public sector, the private sector, in many manifestations. And what this will do in terms of cost to individuals and the other elements of this is just horrific. As I said earlier, what is it, $1,400, $1,700 if you're in your 60s, and make $56,000 a year. You pay $11,000 more under the Republican plan. This is a person making $56,000. So I think that we have to focus on cost and all of the discussions we have and what it means in people's lives. Some of it prevents them from even having access to care. But I will say this, and this is what I was pleased to hear. We know that the mandate was important, the individual mandate, but there are other ways to skin that cat. And I had hoped that the Trump administration would come in and say, I'm not for a mandate, but I know that we can't have any free riders. How do we solve that? You've suggested we can work together to do that, and I think Democrats are very open to do that. All the things that Congresswoman DeLauro and our distinguished whip and other members pointed out that are in the Republicans' bills that relate to stabilization, short-term and long-term, and cost sharing. Let's embrace that and do that right away. It would go a long way. The court case was an intervention. Unfortunately, we thought that the case was clear in terms of it's already called for in the bill. The judge thought not. Now it's up to the president to give us a little more certainty, but certainly Congress can act, as Mr. Elmendorf mentioned. Thank you. And Doug, what do I call you, Mr. President of the Kennedy School? What is the title? Chairman? Whatever's your chair. Dean.
Dean at most, but Doug is just fine,
Doug is
Madam
fine.
Leader.
Dean Doug, thank you for the letter from all of the CBO, directors of the Congressional Budget Office, in support of objectivity, evidence, fact, and data. And thank you all for the evidence, facts, and data that you gave us today to make our decisions. We consider you an intellectual resource. We're blessed by your presentation today, but hope we can count on you further in the future. Thank you.
Thank you, Madam Leader. I also want to thank our witnesses. We here at home, the anxiety that our constituents have as repeal is being considered and what it would mean in their lives. And you have given to us ideas that we can put in action. And I think, as you have pointed out, ideas that our Republican colleagues have acknowledged would be fixes to strengthen, not take away the Affordable Care Act. And again, I have just a particular interest, being a 36-year-old myself and having, constituents in a district that is quite young, that we do everything we can to look out for the next generation of Americans as they go into a much different workforce and have healthcare needs of their own. So thank you for making this an ideas factory, for making this a place where we can collaborate. And we were watching, if you probably observed, the Senate vote as it takes place right now. And it will come down to the Vice President if they have enough votes. And we just hope that whatever happens going forward, your ideas are, I would hope, debated at the very least, and at best put into practice. Thank you again.